Buenos días, vamos a dar inicio a nuestra sesión, que en esta ocasión se engalana con la participación de dos investigadores japoneses que tienen una trayectoria muy amplia en el área de la oncología y específicamente en la parte genómica del análisis de este problema. Tenemos con nosotros al doctor Yoshio Miki. Él es el investigador principal, egresado de la Facultad de Medicina de la Universidad Wakayama, en Japón. Actualmente se desempeña como investigador en la Universidad Médica y Dental de Tokio. Tiene una carrera muy amplia en el estudio del cáncer que inició en Japón en 1989. Él forma parte del grupo que describió el gen responsable de la adenomatosis poliposa familiar y más tarde, cuando estuvo en Estados Unidos, en la Universidad de Utah, fue parte de los que participaron en la descripción del gen BCRA1. De esta manera resalta la relevancia del trabajo que tiene el doctor, que tiene más de 14,000 citaciones al momento de hoy, y de ahí la relevancia de su participación. Vamos a organizarnos en una mesa redonda en donde además participará también el doctor Rui Yamaguchi. El doctor Yamaguchi es el jefe de la división de biología de sistemas aplicado al cáncer en Nagoya, en Japón, en el centro Aichi de investigación, y es también un experto en el área de estudio de genómica del cáncer. El doctor Yamaguchi tiene también una gran cantidad de publicaciones y conforma junto con el doctor Miki este grupo que el día de hoy nos acompaña. Para empezar vamos a escuchar una contextualización de lo que más tarde vamos a estar discutiendo, para lo que el doctor Alfredo Hidalgo dará inicio ahora sí en un idioma común que utilizaremos con nuestros invitados. Doctor Hidalgo, si es tan amable.
Bueno, pues gracias por asistir. Vamos a cambiar al inglés. Today we'll be discussing about a particular issue that has been very important, particularly for breast cancer and ovarian cancer genetics, and this is the detection of mutations in a familial history. More than 75% of the cases of breast cancer at least are sporadic. There are no familial records. And only 15% of this type of breast cancer have a familial component, some kind of aggregation. But only somehow 10% of these cancers can be related to mutations, particularly in the genes that Dr. Miki helped to describe, which are BCRA1 and 2. And as you might know, this is very important because if you have a mutation in your germline DNA, then your risk for breast cancer and ovarian cancer will be very high, more than 80% in some of the cases, depending on the presentation. And that's the relevance of detecting this kind of mutations in the general population, particularly in those people whose genetic history and the familial history suggests the presence of a particular mutation in these two genes. As I already told you, if you compare the risk of someone who is a carrier of this kind of mutations in the germline, the risk can be, at 70 years, it can be as far as 87% of developing breast or ovarian cancer. And now we know that the mutations in BRCA1 and BRCA2 are not only related with breast and ovarian cancer, but are also present in a different set of neoplasms, particularly One very important one is pancreatic cancer and also aggressive prostate cancer. So the spectrum of tumors that are related with mutations in BRCA1 and 2 and in general in genes related with DNA repair is increasing. So it's very important for us to know what is the prevalence of this kind of mutation in this type of tumors and also in the general population. More importantly, some years ago, there were several companies who have developed these molecules, which are the PARP inhibitors, who will be useful for treating tumors of patients who bear these mutations in the germline. So in order to use these PARP inhibitors, for example, in ovarian cancer, you have to demonstrate that this patient has a germline mutation, a hereditary mutation in BRCA1 and 2, and in this way, she can be treated with this kind of PARP inhibitors. Of course, the idea is to treat not only breast and ovarian cancer with this type of inhibitors, but also patients with pancreatic cancer, and there are some clinical trials which are showing that this kind of PARP inhibitors are also useful, for example, in castration-resistant prostate cancer. So it's a very promising area of research, and the application of particular drugs that are already in use can be useful for other types of tumors beyond breast and ovarian cancer. So the problem is that in order to make use of these drugs, you have to test the patients for the mutation. And in countries like ours, sometimes access to this kind of test is somehow difficult. We are defining which is the basic prevalence of this kind of mutations in our populations. So you really need to be aware that in order to make a better use of this kind of drugs, you have to be aware that you have to have access to this kind of test in order to detect the mutations. And what does BRCA1 and 2 do? They are involved in different aspects of DNA repair. There are, as you know, there are several pathways that are related with DNA repair, and in particular, you can use these alterations in DNA repair to exploit them in order to develop different drugs for treating cancer. Some of these drugs are very common in their use. For example, cisplatin that will interfere with DNA replication, and in this case, you can kill the tumor cells. And the new kind of drugs that we were discussing, for example, the PARP inhibitors, will interfere with one of not the main pathway of DNA repair, with another that is less common, and it's only present in some occasions. And the idea is to block this base excision repair pathway in the cells, but it will only work when you have a deficiency in the main repair pathway, which is BRCA1 and 2. That's the importance of detecting the mutations, the germline mutations in BRCA1 and 2, because that's the only way in which PARP inhibitors will work in something called synthetic lethality. In the presence of a particular mutation, you inhibit the alternative pathway using this drug, and in this case, you will kill the cell. If you use the PARP inhibitor without a BRCA1 mutation, then we will see no effect, and the cell will not be killed. So this is the idea, and several of the papers that Dr. Miki have published. It's this correlation between these DNA repair pathways and how you can exploit these alterations in DNA repair for the development of particular drugs for cancer. So the idea is to exploit this situation and detect in those patients which are deficient in the BRCA1 and 2 pathway from their birth, because they have this germline mutation, to select those for treatment. So for that, you need a very access to the test for detecting the mutations. Dr. Miki has also been working in the development and the description of this mutation prevalences in the Japanese population, in the Japan Biobank, something that we have been doing in collaboration with different institutions. We know that there is a particular set of mutations that are common or more common in the Latin American population, but we don't really know what's the basic prevalence of these kind of mutations in the open population. So there are several papers that indicates that it's a good way to analyze the prevalence of mutations in a population, not analyzing directly the patients, but from a population perspective. So this idea has been shown in this paper, for example, where they analyzed BRCA1 and 2 mutations in the UK Biobank, and compared to the clinical data, they found more than 5 more times pathogenic mutations when they do the analysis on the biobank than if they focus on particular sets of clinical patients. So the idea is to develop the analysis of how you can detect the frequency of mutations in these clinically relevant genes from a population point of view. Here in the lab, we developed a project where we analyzed these germline mutations in more than 4,000 Mexican samples, and we were able to detect the frequency of mutations in BRCA1 and 2 in the Mexican population, and this led us to identify that 1 in around 260 Mexicans harbor pathogenic mutations in these 2 genes. This they might seem a little bit high, but you have to take into account that we're not only focusing on breast cancer. Here we are taking into account all the potential tumors that might be related with the mutations in BRCA1 and 2. So this is one of the first approaches where we use population genomics in order to define the frequency of mutations for a clinically relevant gene. And we might learn from the experience of Dr. Miki in Japan how it compares with the frequency of this kind of mutations in other populations. So the idea is to analyze this, and what is the future for this kind of test? Right now, we are only focusing on those patients which are where their familial analysis suggests that there is a familial component. But right now, there are some changes and there are suggestions that every single breast cancer and ovarian patient should be tested for mutations, not only in BRCA1 and 2, but using extended panels in order to identify alterations in the whole pathway of DNA repair. So this will, of course, increase the number of patients that might benefit for this kind of drugs, and will also increase the frequency of pathogenic mutations that we find in this type of patients. And we have also to be very careful, and we have to be prepared in order to have everything for testing all this very high number of patients, not only for breast cancer, but also for pancreatic cancer and for prostate cancer. And the other thing that we should take into account is that you cannot only focus on the germline mutations. There is evidence that suggests that if you find BRCA1 and 2 mutations somatic in the tumor, those patients might be also benefit from PARP inhibitors. And also, if you use another set of tools, algorithmic tools using whole exome or whole genome data, you can analyze what is called the mutational signatures of the tumor. You will analyze how the mutations are distributed along the genome, and you might be able to detect particular mutational signatures that are associated with a phenotype that is called bracketness. And there's evidence that if these patients with a bracketness phenotype are treated with PARP inhibitors, they will benefit from this kind of treatment. So as you can see, and we will discuss further with Dr. Miki, there are several points of actions where we can use genomics in order to identify which patients will benefit from drugs that are already existing, and how you can use these alterations in DNA repair pathways in order to better select patients for treatment and for the better development of drugs for this kind of tumors. So with this short context of what we will be discussing, maybe we can just, you can join us in here for the talk. Come on. And the idea is to have some discussions about how genomics and how the alterations in the DNA repair pathways can be helpful for clinical applications. Please go. Nos va a acompañar también la doctora Carmen Aláez, que es la jefa del Laboratorio de Genómica del Cáncer, del Laboratorio de Diagnóstico Genómico, y quien tiene pues una amplia experiencia en detecciones de mutaciones en BRCA1 y 2 en general, y en cáncer familiar en este sentido, ¿no? So, So, Dr. Miki, I don't know if you can just give us a brief overview of your work regarding how you're exploiting these alterations in DNA repair pathways and in the clinical setting. In your experience, how you're exploiting these alterations in the DNA repair pathways for finding novel mechanisms for treatment, or how you're using this knowledge to benefit treatment?
Oh, yeah. It's a very difficult question for me. I'm only a basic scientist, and I am searching the mechanism of BRCA1 and BRCA2 for a long time, and 2005, it was reported that BRCA1 and BRCA2 deficient cell are very highly sensitive to PARP inhibitor. So I think this is the first evidence that BRCA1 and BRCA2 deficient and PARP inhibitor. PARP inhibitor is a DNA damaging agent, and these two defects lead to the synthetic lethality. But this is already, I don't know the name. So the synthetic lethal approach of HBOC patient, the clinical trial proceed the basic science. Mm-hmm. Okay? So yes, it is very important to study the molecular mechanism of BRCA1 or BRCA2 or some other causative genes for hereditary cancers. But the clinical trials are very powerful. So now I am thinking about how can we apply our evidence to the clinical trial? But it's a very difficult question, I think. Mm-hmm. Mm-hmm.
I would like to ask you something. I would like to hear your thoughts about the use of other Fanconi genes with PARP inhibitor. What do you think about that possibility? Because in Mexico we have patients with other Fanconi genes mutated that maybe in clinical trials could be benefit using PARP inhibitors. What do you think about that?
Your question is, Fanconi anemia patient is sensitive to PARP inhibitor or not?
No Fanconi anemia, other breast cancer patient with Fanconi gene mutated, PARP2 or
but
genes in the same pathway.
Yeah. Fanconi anemia pathway is required for the interstrand cross-link repair. Okay, so I'm not sure, but anyway, BRCA1, BRCA2, or other genes associated with homologous recombination repair, these genes, mutations of genes, the patient is very sensitive to the PARP inhibitor. But the Fanconi anemia pathway is slightly different. So it's a very tight association of BRCA1 and BRCA2 and Fanconi anemia responsible genes, but I'm not sure Fanconi anemia patients are sensitive or not.
Thank you.
From the experience that you have in the analysis of BRCA1 and 2 mutations in the Japanese, in the Japan Biobank, do you see a higher number of mutations in the population compared when you only sequence clinical in a clinical setting? You also find more mutations if you focus on the population side.
So you mean the anyway, BRCA1 to germline mutation and somatic mutation and genes, other genes associated with the HR, homologous recombination repair. All genes are very important for the PARP inhibitor treatment. Mm-hmm. But I have no precise information. What percent of the patients and maybe 5 to 10% of the breast cancer patients have germline BRCA1 and BRCA2 mutations. And 2 or 3% of the breast cancer have somatic BRCA1, BRCA2 mutation. But we have no information about the mutation frequency of other genes of rather than BRCA1 and BRCA2.
Mm-hmm. Okay, thank you. Now, Dr. Yamaguchi, he's an expert in artificial intelligence and how you applied artificial intelligence in exploring how you can link data in the health system. So, in your experience, what will be you will need a standardized clinical medical record in order to do this kind of analysis. What is the experience in Japan right now about this kind of electronic medical data?
Thank you. So I'm a data scientist to analyze genomic data and to interpret to use by using the AI-based assisted system. And in Japan, we're still we just start to integrate such kind of electronic health record into such kind of genomic medicine, and we have several scattered systems, so different standards or format in the electronic health records. It is difficult to integrate. At this moment, it is difficult to integrate into the genomic medicine, such kind of system. So we, in some Japanese group, has already started to integrate our unify the format of the electronic health records.
And you're already planning to a way to incorporate genetic testing data in this kind of analysis, I guess.
Yes, I think in Japan, in this month, some cancer genomic testing started to covered by Japanese health insurance. And but still, such EHRs are not integrated into the system. But from now on, I think to expand such kind of genomic medicine into the panel and exome and whole genome sequence. So it is necessary to integrate the unified EHR system into the such kind of genomic medicine.
Mm-hmm. In order to decide which patient could use the therapy, are you using only BRCA1 and BRCA2 tests, or are you using an extended panel for Japanese population?
In the research level, some researchers to use the BRCA mutation to select for further expanded panel or exome, but in the approved, approved by the or covered by the health insurance system, they don't care about the BRCA mutations, but all kind of cancer patients after several second line or third line therapy are covered by such kind of medicine.
And regarding, that might be for the two of us, how do you envision the future in population genomics use for early detection or for prevention? Whole genome association studies have been great to identify potentially variants that increase the risk. And some of these have been already organized into polygenic risk scores. What's the status of this kind of scores in Japan?
It's a good question. In some research groups started to identify such kind of biomarkers based on the whole genome based such kind of BRCA phenotype or polygenic scores, but it's not still not integrated into the daily genomic medicine, but it's still research level.
Mm-hmm. Mm-hmm. And regarding, Dr. Miki, regarding other types of tumors, for example, colon cancer with KRAS mutations, what's your clinical experience in that sense?
You mean the breast cancer?
No, in colon cancer, for
Colon
example,
cancer.
with KRAS mutations,
Yeah.
what is your experience in that sense?
I have no idea. Because my major is breast and ovarian cancer. So
Okay.
yeah, the KRAS mutation is a very difficult to develop the molecular targeted drugs. Okay, so yeah.
Okay.
I have an extra question. What happened with the VUS, with the variant of uncertain significance and the treatment? What happens if you sequence the tumor or you sequence germline mutation and the patient is advanced stage? What happens if you find a variant of uncertain significance? You go further with the treatment, or you say no because it's a variant of uncertain significance? Which is the position in Japan about that? Thinking in a patient that you have nothing to do except do something. No?
So I'm not a patient, so, but for me, it's a very important to annotate the VUS or BRCA1, BRCA2. There are a lot of VUS in the public database. And I'm not sure what should we do for the patient with VUS. Okay. Yeah, that.
What do you think, Dr. Miki, for example, the role of other genes, for example, kinases, amplification of CDK, it's somehow common in breast cancer. What do you think that will be the role of this kind of new biomarkers in both in the general knowledge of how the cell cycle is altered in breast cancer and potentially to be also used as biomarkers for other inhibitors, for example, CDK1 inhibitors?
So CDK4 and CDK6 inhibitors, for example, there are some kinds of biomarkers for using the PARP inhibitors, BCRA1, BCRA2 mutations, or homologous recombination deficiency, or some other kind of biomarker we can use. But for the CDK4 and CDK6 inhibitors, maybe the biomarker is triple negative, estrogen ER positive, or maybe subtype of the molecular subtype of some, I don't know. Anyway, so it's very difficult to use a biomarker for the CDK4 and CDK6 inhibitors.
Si alguien tiene alguna pregunta del público. Por favor. ¿Por qué no la dices? Fuerte.
My question is for Dr. Yamaguchi. Respecting AI informatics, is there a possibility, here in Mexico we have a problem with resourcing, and mainly in the clinical aspect, right? And the first contact with the patient. So is there a possibility that AI can become a good tool for predicting mutations with only clinical information of the patient, without a biological test? For example, I have a patient, 40 years old, and she comes to my to my clinical practice. She has a lump on her breast of 2 years of evolution, and she has her mom and her grandmother have had breast cancer. So is there a possibility for me to input that into an algorithm, a predictive algorithm, and say, for me to know if there is a possibility that this patient has a mutation, and for me to have a more justified answer as to say to send that patient to a biological, say, sequencing or a microarray test, and even make a better discrimination of my patients, and not send every patient to a sequencing or microarray, and make a better use of my resources. Yeah, that's my question.
Thank you for the question. So you're asking about to identify the patient that have particular mutations, to identify such kind of mutation patient by using without mutation testing?
Yes.
Okay. Okay. Yeah, I think, it's very interesting, important part of the medicine, so to reduce the cost of the medicine. Yeah, there are several, for the BRCA or breast cancer patient, it's important to ask the family history for the stratification. And also, there are several studies to identify mutations without genetic testing to see the pathological images of the cells. Yeah, there are several studies, and to identify to identify such mutations, not by using the deep learning algorithms. Yeah, it's a possibility.
Thank you.
Por allá había otra pregunta.
Maybe piggybacking a little bit on the last question, I'd like to ask you about your experiences regarding the relationship between basic science and data science with regards to oncology. It can be for both of you, actually.
Oh, okay. You're asking about my experience?
Yes, the experience that is happening regarding the way that basic science is getting enriched by data science and vice versa.
Oh, well, that's a good question. So I started this kind of study 10 years ago. So at that time, the basic science and the data science and the clinical science is very far. But after the introducing the next generation sequence technologies, the distance is very near and near, and for future, so data science and the basic science and the clinical science is firmly integrated. So that is the future. So from my experience.
I think mostly in oncology, the challenge for integrating the big amounts of data that are coming, for example, for a whole genome, a whole exome, and how to integrate that into medical records will be one of the biggest issues, particularly from a computational point of view. How is Japan dealing with that kind of questions? Do you have a central computer or?
Yeah, so computing resource that's required for analyze the genomic data. So it's so for 5 years ago, just we started. So using the cutting-edge supercomputer system. To analyze the whole genome sequence data, it requires 1 week for a patient. But after that, so improved, the technologies are much improved, especially by using the GPU technology. The GPU is the parallel processing unit in the supercomputer system. So by using that kind of the algorithm that uses the GPU system, so it requires only 30 minutes or less than 1 hour using to analyze the tumor and the normal pairs data. So that was a bottleneck of the whole genome-based genomic medicine, but it's already solved. But the bottleneck is the time for the interpretations. So there's so many mutations that was obtained from the whole genome sequence. So we are studying to interpret such kind of whole large number of the mutations by using the AI-based system.
Algunos de los alumnos que trabajen con reparación de DNA, si tienen alguna pregunta para el doctor Miki. Sí.
Regarding the variants of undetermined significance, is there any new tools developing basic or bioinformatic tools to help us determine the real significance of these variants?
So you're asking how to predict the importance or impact of the mutations using the algorithm?
If there are any new tools, we have some of them in the literature, but I don't know if there are any new that are right now developing.
Tools?
Yes.
Oh, yeah, there are several tools to predict the impact of the mutations. So based on the conservation of the multiple species of the proteins, the site, or other machine learning-based method. So, for example, recently Cambridge University's group published to the biomarker to stratify the patients, of the triple-negative breast cancer patients. They use such kind of machine learning-based algorithm to stratify the patients.
And in the basic research, is there any new things that we should know?
New thing?
Yeah, in the basic research.
Yeah, I think there are many new tools, yeah, to develop. Yeah, especially for the future. So there are many whole genome sequencing data. So currently there are very few tools to interpret the structure variations or no coding part of the mutations. But there must be important mutations that could not be interpreted at this moment, but there will be the new tools.
Hi, nice to meet you both. Thank you for being here. And I will try to do my best with my English. The question is for Dr. Miki. In your experience, you have been in, Japan and the United States, and you've been working there with research in hereditary cancer, breast hereditary cancer. So I understand that in Japan, it's not as strong or is not so developed. The research in that area is not that strong, like stomach cancer or colorectal cancer, for example. Breast cancer is like starting to gain a new punch, like more, being more strong in Japan. And in United States, as we saw, it's already very high and very strong, the research in this field. So in your experience, it's very different, the approach in the research that is made in Japan about hereditary cancer. It's like learning more about the research that is happening in the United States, or the population is different, and that's why you are taking new ways, or you're approaching the research in hereditary cancer in a different way, because it wasn't that strong like in the United States. I don't know if I make my question clear, or is too much too much information and too... I don't know if I make myself clear, or I will try again. No, I wasn't clear, right?
So you're asking there is a difference between Japanese population and US or Mexican?
No, how do you see the research how research is made in America versus Japan. The approach is the same, or you doing this approach different? Because I see that there is no so much groups or centers in hereditary breast cancer in Japan like there is in America. So that's something that take out my curiosity when I look forward in Japan. Again, I was not clear, right? I'm terribly sorry. Do you see big difference between research in America that research in Japan in the field of hereditary breast cancer?
I'm not an epidemiologist, so I have no idea. But I think there is a difference between Japanese population, or in Asia, there is a difference between Chinese population and Japanese population. So there is a many difference between each species, but I don't know how we can detect the difference. It's a very difficult problem, but also very it needs a great effort to make a big database covered all over the world. Okay.
Okay. Thank you so much.
Hi, I think my question is for Dr. Miki, but I'm not sure. So I think a dream would be to have all the clinical information and genotypic information in one single resource. So do you know any national effort, maybe in Japan or in the US, to have all the clinical and genotypic information centralized? So every researcher could see if a specific variant is in, I don't know, 100 patients with some clinical specific characteristics. Do you know any effort in this, like this? A resource in which all the clinical and genotypic information could be stored, and every researcher in that country or maybe in the world could access that resource.
It's something like UK Biobank or something like that, but I guess there is an effort in Japan for that, no?
Maybe specific for BRCA, for cancer.
So I would like to answer some part. So as I mentioned, in this month, in Japan, they started to the cancer panel testing for the solid tumor patient, and all of the information, clinical and the mutation information gathered into a single center in the National Cancer Center in Japan. So that will be the good resource for the interpretation of the mutation, but there's still limited in the panel that's called limited number of the genes, and also the collaboration in the worldwide other worldwide resources are still not started, just started in this month. Okay.
La última pregunta, por favor.
Yes, this is for Dr. Miki. I wonder why does the mutations on these genes happen from the biological point of view?
Your question is why BRCA1-2 mutation causes the cancer, ovarian or breast or ovarian cancer?
No.
No?
Why do the mutations occur?
Oh.
From the biological point of view?
Yeah, it's very difficult, but many sources are for example, radiation and natural radiation from space or UV light and many environmental toxins damage the DNA. Okay? So, but I don't know how these toxins or these sources damage only some specific genes, for example, BRCA1, BRCA2. But I think some mechanisms for the damaging to some specific genes. Yes, there is some reason, but I'm not sure now.
Thank you.
Perfecto, pues con esto terminamos. Les agradezco la atención y por favor un aplauso para los miembros del Gracias.